conclusion. So I talk a little bit about therapies to give you a flavor of what is happening in the treatment realm within sickle cell disease. So my disclosure, I am involved with research studies and with grant support around these research studies. I do not get paid by any particular, I don't get paid by any of them. It's all through the research studies. So very briefly, you're very familiar with this, this cartoon and schema of, but I'll just remind you, sickle cell disease is a single amino acid change that results in within the hemoglobin molecule. And as a result of this single tiny little change, this creates a whole systemic disease of significance. So hemoglobin S is less soluble than normal hemoglobin. And when the red cell gives up oxygen, those hemoglobin molecules polymerize, and that results in, part of that results in the change in shape of the red cell. So red cells are developed normally with patients with sickle cell disease, and when the red cell gives oxygen at the tissue level, for example, at your muscles or wherever your organs, there is a change in shape, and that is partly responsible for the vaso-occlusion, which you're very familiar with. The hallmark of disease is pain. We now recognize that it's not only an obstruction or blockage of blood vessels that results in pain, in vaso-occlusion and bone pain, etc., and organ damage, but it's more involvement of white cells, platelets, and the lining called the endothelium of the blood vessels. And with this understanding, this is what is exploited. These areas are exploited to try and find therapies. And just as a hematologist, I could not show you a smear. So this is what your people with sickle cell disease, when in an active crisis, you have more of these sickle cells, but you still have some of these irreversibly sickle cells on a blood smear within the blood circulation at all times, even outside of a crisis. So you saw this slide once before, but just to illustrate clinical advances. So in the early 20th century, sickle cell was described in the United States from a patient who was from the Caribbean, from Grenada, and that started the recognition that this is in the Western world. Sickle cell disease is thought to have evolved as many as 7,000 years ago in the Sahara, at the time when the Sahara was, the theory is, at a time when the Sahara was not a desert, it was a forest with lots of mosquitoes. And then the gene was perpetuated. There was those patients who had sickle trait had some protection. So very little happened in the early 20th century, and then Ronald Reagan through the National Sickle Cell Control Act, a lot of advocacy from families and patients and healthcare workers. And then with that came comprehensive care centers and the recognition that with comprehensive care centers, with comprehensive care, patients can actually do very well. And then in the early 80s, we had preventive penicillin, the prevention studies which were done, which made a big difference, because one of the main causes of death in sickle cell disease in children under the age of 5 is pneumococcal sepsis. So penicillin prophylaxis was studied. Later on in the 90s, hydroxyurea, and then slightly later on, the need for transcranial Doppler screening and stroke prevention started. Stroke, 1 in 10 kids under the age of 20 will have a stroke, and this is, to me, has been one of the biggest in my time of managing patients, the biggest change to allow patients not to have strokes. And so when people ask me now, what is lifespan of patients, this is what is written in the literature, but I know many very much older people who have sickle cell disease and are thriving in life. So I don't like talking about life expectancy. Other clinical advances other than newborn screening, comprehensive care, infection prevention, brain injury, transcranial Doppler prevention, hydroxyurea, transfusion safety. We now have safe blood products. Hepatitis C, HIV were a big concern in the transfusion world, and this now since the 80s we screen patients between donors so that patients can feel much more comfortable receiving transfusions, and me as healthcare worker feel more comfortable transfusing, of course, only when absolutely necessary. With chronic transfusions, for example, in brain injury prevention, stroke prevention, comes iron overload. And fortunately, at this point in time, we have 3 iron chelators that are licensed that we can use for our patients. Lung injury prevention, surgery, anesthesia, safety. We've had trials on transfusions around and perioperative management, and it's now safe. Everybody's more aware of things to do, and just the education around a patient with sickle cell disease having surgery needs to increase, I think, everywhere, because we still see, even here in Ontario, we have an occasional patient with sickle cell disease who's put to sleep for a surgery in a peripheral hospital or something without awareness of potential for postoperative, the need for good postoperative care. Pain management is a hallmark of sickle cell disease, and pain management is improving. Still a long way to go. Kidney disease, and more recently, severe disease with transplantation, which I'll talk a little bit about. So what are the targets for therapy for sickle cell disease? Within the bloodstream, we have red cells, which we're very familiar with. We also have white cells, which play a role. We have platelets, which are little cells that stop bruising and bleeding, and also by forming clots. And then we have exploit the endothelium of blood cells, which are also can be a target. So I'll just start with hydroxyurea because that is the backbone for us and most places for care of patients. It's a less expensive medication, and approved in 1998 by the FDA, and the indications are now far and wide. Initially, we would only give patients who were very sick hydroxyurea, but now it's a major comfort level. So we start hydroxyurea even in the pediatric population, and through NIH, we follow the NIH guidelines. With our own guidelines are adapted from the NIH guidelines, and we put many of our patients on hydroxyurea. Many of you are familiar with hydroxyurea, and if you're not on hydroxyurea and and being unwell, you should talk to your doctor about hydroxyurea. It's once a day pills, and it's quite safe. And we have now many studies going back several years from the early 90s. There's evidence to suggest that hydroxyurea is effective in decreasing the frequency of pain episodes and other acute complications in adults and children with the most severe genotypes. We can prevent life-threatening neurologic events in those with sickle cell anemia at the risk of primary stroke by maintaining transcranial Doppler, by screening and this screening with transcranial Dopplers, but also there's now some suggestion, it's not proven, it's some suggestion in the pediatric population that early hydroxyurea initiation may prevent the vasculopathy you get in sickle cell disease. And we have shown that hydroxyurea prevents the decline in lung function in our teens with sickle cell disease. So just to show you blood smears. This is one of our patients prior to hydroxyurea starting. You can actually see sickle cells quite misshaped because they're in different stages of becoming sickling and unsickling. Within 6 months, you start to lose seeing those sickle cells, but it's still not perfect. And this patient was actually, this smear was done at 2 years, but we've seen that at a year of age, the clinical response and improvement in health. And at peripheral smears, these are quite normal looking red cells. And if you just showed me this smear only, I could not tell that this patient had sickle cell disease.